Well, I want to thank all of you for being here for another of our class of 67 Zoom presentations. And tonight we're fortunate to have Ed Wing with us. He's speaking on his personal journey of treating HIV, which has gone from a fatal, terrifying disease of death to a chronic illness. And Ed was, I believe, well known by all of us as an athlete and a scholar at Williams. And he ground out a lot of yardage on the football field and in the science labs and ended up graduating magna cum laude. Then went on to Harvard Medical School, where he graduated just cum laude. And he did his medical residency at Peter Bent Brigham Hospital in Boston, and then received and completed an infectious disease fellowship at Stanford. He started his career in academic medicine at the University of Pittsburgh and stayed for 21 years, where he became the chief of infectious diseases and the interim chief of medicine. Then moved on in 1998, he became the chair of Brown's Department of Medicine and just retired last year. His focus has been on immune host defense against cellular pathogens. I have to be able to say it. There we go. And he's overseen programs in Kenya, India, Dominican Republic, Cambodia, Vietnam, and Russia, while working directly still with hundreds of patients during his long career. He's written extensively for medical journals on infectious diseases, and you have, I think, been sent an article that he wrote on HIV and aging. Now that he's retired from the chair of Brown, he is, we're just finding out, doing a whole lot of other things and getting involved in many things. But one of them that really tweaked me was he is teaching 3 sections of a very, really very popular undergraduate course on C.S. Lewis, Beyond Narnia. And it seems to be the one that a lot of people want to join. So Ed, you've continued to really exhibit lots of energy and commitment that you had while you were at Williams throughout your career. And we look forward to hearing from you tonight. So thank you for being here. We really appreciate having you.
So thank you very much, John. I really appreciate the opportunity to talk. And when I talked to John and Alan, and I said, what do you want me to talk about? I said, I'm sure you don't want me to talk about my career in academic medicine or deans or chiefs of medicine. And he said, yep, we don't want to hear that. So I said, well, let me talk to you about something which has been very meaningful in my life. And what I've spent a fair amount of time doing, and it's really outside of any administrative jobs that I've had, and that is the HIV epidemic and my care of patients in the epidemic. So let me start out. And when I first heard about HIV, it was in 1981 when I was traveling to a conference with a infectious diseases colleague, Frank Reining. And we were startled by hearing on the radio that 5 young men in Los Angeles had gotten a very unusual infection. It's called pneumocystis carinii. At the time, it's now pneumocystis cerevisiae, but it causes pneumonia. And when we were at Stanford together, we saw that, but only in heart transplant patients who were really immunocompromised. So this made no sense to us. Why would these 5 young, healthy men have gotten this infection? The news was followed by reports from New York City of another group of people, all intravenous drug abusers, who had gotten the same kind of infection and additional infections. One of them was Kaposi's sarcoma. So Kaposi's sarcoma is a skin cancer, which is very unusual in most people. It occurs rarely in older men who are of Mediterranean descent. So this, in these young people, just again was very unusual. In addition, they had other types of infections. They also had fatigue, weight loss, chronic diarrhea, and most disturbing, progressive dementia. So HIV is usually a silent disease, as you may know. For years, you get it, and you may have an initial series of mild symptoms, and then it's silent for years. But once infections occur, you're said to have AIDS. Your immune system does not work. And once you have AIDS, it's a death sentence. You really only have 12 to 18 months at the most to live. So I didn't know it at the time, but I was beginning a 4-year journey taking care of what I think are very courageous patients who endured a progressive disease that affected both their minds and their bodies. And I saw the pandemic from the beginning, when there was no treatment, it really was a death sentence, to a time now where treatment consists potentially of 1 injection every 2 months. It was a disease where infection and death came invariably, but now it's totally chronic and totally controllable. It's a chronic disease. Then patients can lead a normal life. So a huge, huge change during the time that I've taken care of patients. So before I go on, let me just return to when I left Williams. I remember driving away from the campus. I got married that summer to Rena Rimsky, who was my high school sweetheart. She actually wasn't a sweetheart for my entire time at Williams. She broke up with me. So 1.5 years, we didn't go together, but then we got back. Actually, I think she came up to, because I told her what my stats were in this when I was a tailback, and she said, well, give the tires another kick and see. But we eventually got married. And then as John said, I went to Harvard, trained in internal medicine, and then at the Brigham and Women's Hospital, which is used to be the Peterbent Brigham Hospital. I next joined he didn't mention, I was in the National Health Service Corps, which is a branch of the Coast Guard of all things. And they assigned me to a former steel town outside of Pittsburgh, and I practiced general medicine for 2 years. But I knew from medical school that I wanted to be an infectious diseases specialist. But at that time in medical school, several senior clinicians said I would be a much better surgeon than an infectious disease person. And they actually said infectious diseases was a dying subspecialty. People said infectious diseases had been controlled with vaccines and antibodies, and that ID specialists would have nothing to do but sit around and culture themselves in the future. So it is ironic that new severe infections and epidemics were occurring at that time and have continued to occur right down until the present day, as you know. When I was in an infectious disease fellowship at Stanford from 1975 to 77, there were 3 new infections identified during just the 2 years. So they were Legionnaire's disease, Lyme disease, and Ebola virus disease. So new infections just proved the lie to what they were saying. I mean, even during a short time, very significant infections occurred. So during my career, there's been new infections and variants of old infections which have occurred constantly. And the latest is COVID-19. Oh, I forgot, monkeypox, and then who knows what the next one would be, right? And I actually have a list of some of the ones that were discovered during my career, so we can talk about that later if people are interested. But it's this continuing changing landscape of infectious diseases, new infections, resistant strains of viruses and bacteria, and the changing epidemiology of infectious diseases that has always fascinated me. And I love the fact we get patients better. So the follow-up clinics in ID are short because they're better. We don't have chronic clinics typically, and we don't deal with chronic disease. So my optimism about going into this field was really shattered by HIV. We didn't know what caused HIV initially. So speculation ranged from things like drugs like amyl nitrate to other unknown substances. Really, people bandied around all kinds of possibilities, to microbes such as viruses, which it turned out to be, or something unusual about the lifestyles. And we didn't know a lot about lifestyles, and particularly the gay community. So we didn't know that whether those were contributing as well. So when the epidemic started and it started becoming very severe, I was an assistant professor at the University of Pittsburgh, and I was doing what people do. I was doing research. I was teaching, I was taking care of patients. And one of the first patients I cared for with HIV was a priest from the Midwest who was in his 30s. When I saw him, he was a slight, quiet young man, very pleasant, but he was partly blind. His family was with him and they were very worried. We suspected he had HIV and we diagnosed CMV retinitis. So that's cytomegalovirus retinitis, which is a viral infection of the back of the eye. Our therapy for retinitis at that time was limited, and he went rapidly downhill and became blind, despite our efforts at that point. He became wasted. So when people are wasted, that really means they've had a lot of weight loss, and you can just see it. Their temples are sunk, and their eyes are sunk, and they just appear not well. He became unresponsive from the dementia, and he died. He'd come home to be cared for by his close-knit family, and their boy had been the pride of the family, and now the family lovingly cared for him as he died. So it was tragic, and I couldn't save him and felt terrible. Another patient was a young, tall, bright man who complained of walking difficulty. My neurological exams showed that he had severe cerebellar dysfunction. He was really wobbly. He couldn't walk well at all. We did a brain scan of him, and it suggested a very unusual infection in healthy people. It's called progressive multifocal leukoencephalopathy, or PML, and it's due to a virus which is seen only in severely immunocompromised patients. So this was somebody in finance, and he had done well financially until recently when he lost a lot of money. He was also a chess player, and he'd forgotten how to play. So it was really tragic. He had an attentive family, but they were angry with me because I couldn't make him better. I couldn't offer him very much. And they also called in HIV advocates at the time, who were pretty aggressive people, and they didn't like what I was doing. They were second guessing everything I did. But there was really nothing that I could do and nothing that they could do to save him. And he progressively worsened and died. So that was the story of early patients. I also cared for a very attractive young Black airline stewardess. She was from the Caribbean and had a great personality. She was cheerful throughout her illness, appreciated all of our efforts. She slowly got worse and eventually was placed in a nursing home where I visited her. And it was just terrible seeing this young, vibrant woman who had been ravaged by the virus. She became demented and died. And there were hundreds of other patients like that who had the same outcome. So it's really distressing. It's very discouraging for me, who was trained in infectious diseases. My patients were supposed to get better. So the worst childhood illnesses like polio and diphtheria and measles had been controlled with vaccines. People forget about this, but the scourge of cholera and other waterborne illnesses have been largely eliminated by modern sanitation and water purification. When I was in Pittsburgh, the history of Pittsburgh was cholera. There were waves and waves of epidemics until they started filtering the water, and then everything went away. It was about the early part of the 19th century. Things like tuberculosis, pneumonia, meningitis, staphylococcal and streptococcal infections, I can treat. We get patients better. With HIV, though, I was helpless. It was the inevitable immunodeficiency marked by falling CD4 counts in the blood. So I'll talk about that in just a minute. The development of infections, and then just inexorable, terrible death happened over and over again. It was like oncology. I felt like an oncologist, but I didn't have any of the anti-cancer drugs or surgery. As terrible, and it was very clear taking care of these patients, was the stigma and worse, the isolation that these patients endured. And I can tell you, they were shunned by society, people were afraid, and by some doctors who were not following the Hippocratic Oath. I felt horrible for my patients and helpless against the disease. I remember being in my church and seeing an exhibit of quilts made in the memory of young men who had died of HIV, and they were gorgeous quilts. They just show, and all kinds of things representing the life of those young men. Each quilt memorialized their lives, and each quilt represented the failure of medicine and in turn myself to make the patients better. For the first few years of the epidemic, we had treatment for the infections and tumors that patients with HIV developed. I could treat pneumocystis carinii, but it was only temporary and it didn't last. We couldn't change the course of the illness. And really, it was just a course to death. It reminded me of one of my favorite movies, The Seventh Seal by Ingmar Bergman, which has a knight playing with chess, and he knew if he lost, he was going to die. And it ends with death with a scythe dragging a line of the condemned along a hilltop at dusk. So that's what I felt like was happening with my patients. So there was the next stage is we started to have some treatments, starting very slowly. As I said, we didn't even know it was a virus until 1984. But we did know that it affected gay men, IV drug abusers, hemophiliacs, and people who got blood transfusions. It also became clear that you got the virus through sex, primarily anal sex in the US, sharing needles or blood products. And we soon could monitor the disease by measuring the number of viruses in the blood. And the result of that test is called the viral load. So we could do that and identify people who had the disease and follow the course of the disease. Just a little bit of an ID here. The virus turns out to be an RNA virus, which means its genetic code is in RNA. It infects certain cells, specifically the white blood cell that I mentioned, the CD4 lymphocytes, a T lymphocyte. The virus enters the CD4 lymphocyte, was converted into the patient's own DNA, and then reproduced, killing the cell and releasing more virus. And it happens hundreds of millions of times in a very short period of time. The CD4 count in our blood is normally between 500 and 1,500, and it's used to monitor the course of the disease. In HIV-infected patients, the CD4 count steadily declines. You can just measure it in these people, just absolutely a straight line down until it's less than 200. And when it's less than 200, they're said to have AIDS, the acquired immune deficiency syndrome. And they're extremely susceptible to opportunistic infections and tumors. And that's what I said, that's sort of the very rapid course to death. AZT, or zidovudine, was introduced in 1987. That was the first effective antiretroviral drug. It blocked the conversion of HIV RNA into DNA. So remember, RNA has to get to DNA. Well, this blocked it by an enzyme called reverse transcriptase. So AZT is a reverse transcriptase inhibitor. It made patients sick and had side effects. So it was toxic to the bone marrow, very expensive, but it was effective. So you gave patients AZT and their viral load went down and their CD4 count started to come up, but it only lasted for a couple of months and the virus in the body mutated and started multiplying again. So it was good for a few months, and then the patient started getting sick again. So it was like a little glimmer of hope, but it really didn't work on the long term. It was reasoned that adding a second drug similar to that, similar class, would prevent resistance. And we did that. So people were taking two drugs. It wasn't easy, but they were better again for a short period of time, but the virus mutated. It could get past the two drugs and then start multiplying again, and the patients got sick again. So despite these early attempts at treatment, by the early 1990s, the number of cases of HIV in the US was over 100,000 per year, and it accounted for 50,000 deaths per year. It was the leading cause of death of men between the ages of 25 and 44. So that was our generation, right? So in 1995, a new drug with a new mechanism of action was introduced. And when I just first started thinking about this talk, I had all the drugs lined up. And my wife said, please don't do that. That's just not going to help. So the names are being withheld for a good reason, I think. So a new drug came along. When the three drugs, so that new drug plus AZT plus a second drug like it, was added, the virus couldn't mutate. It just couldn't get past that barrier. And the regimen worked. It was like a miracle, really. It was one of the miraculous medical advances of this past century. Once the regimen was started, patients' immune systems slowly recovered, as did the patients. And even those who had no CD4 count, lymphocytes or count, which is the end stage condition that I mentioned, they partially recovered, and many of them could lead a normal life. But the initial combinations were really tough to take. They were large pills, and you had to take them every 4 to 6 hours. And the side effects, particularly the gastrointestinal side effects, were really rough. So patients during that period were very thankful that they had, finally could take something which would keep them alive, but they found it hard to take. I had a young man in his 20s who worked in a nightclub and found it almost impossible to take the pills. He had to take them every 4 to 6 hours, even during his working time, and take up to 24 pills per day. They made him sick, made him woozy, but the alternative was ineffective control, AIDS, and death. So he struggled to take it, and he did. He managed to take it, and he lived. So it was just a huge turnaround. I had another patient, though, who could not even swallow his pills. And whether this was physical or phobic about HIV, it was hard to tell. Taking the pills for some patients was very hard psychologically. It was like running up against their denial. So if they took pills, they had AIDS. If they don't take the pills, maybe they don't have AIDS. So this guy couldn't take them. We had speech therapists and swallowing experts working with him. Nothing worked. He eventually was lost to follow-up and presumably died, but just couldn't stomach this difficult regimen to take. And I had a final patient from that era who had AIDS. He was very immunocompromised, and he developed a type of infection, unusual blood infection, almost never seen in healthy people, called Mycobacterium avium intracellularium, or MAI. You have to be able to pronounce a lot of things like that to be an infectious disease expert. That sort of distinguishes you, from other people. So I had selected an antibiotic to treat this MAI, realizing only later that a newly described drug interaction had made the HIV drugs inactive. So over time, the patient's CD4 count fell, and before I realized it, he died. I could have used an alternative and potentially saved his life, but I didn't. So no excuse. I still think about that as one of my failures. It was a total failure, but I can't forget it. There were other tragedies during this time too. Despite the effective antiretrovirals, a young, seemingly healthy, attractive woman in her 20s from a wealthy family in New England became addicted to heroin. To support her habit, she spent time as a prostitute in California. But she came into the clinic to see me and be tested for HIV. And she was tested, and it came back positive. When I told her, she sort of had a blank expression on her face. She excused herself and went into the bathroom. She came out with her arm bleeding. She had just shut up. That was her solution. We were able to start antiretroviral drugs on her, though, and I admitted her to the Salvation Army Drug Rehab Program in Providence, which is a really good program. Several weeks later, I learned that she'd been kicked out of the program, and I was really upset. And I went down to the program, insisted on seeing the director. I said, what's the story on this? And he gave me a tour of the facility, and I realized how good a facility it was. And I asked him what happened to my patient. And he said, she broke every rule from day one. She could not stand the discipline, being away from her drugs. There was no way they could keep her. And years later, I learned that she died somewhere in the Midwest. So, another one of these tragedies, even though we had drugs, it didn't work for this woman. It's really very sad. So let me totally switch, and I'm going to go to another continent, and that's Kenya. So in 2001, I'd taken the job as chairman of medicine at Brown University, and with the help of a young faculty member, Jane Carter, agreed to start a exchange and educational and research program in Kenya. And that's one of the advantages of being a chair or a dean, that you have money. And so I could actually do something like this and support it. When I traveled to Kenya for the first time, I had no idea I would be entering a time warp in terms of HIV and medicine in general. It was like going back to the beginning of the AIDS epidemic and to an earlier time of medicine. On my first day in Eldoret, which is a city in northwest Kenya, I walked to the hospital from our dormitories, which is always great. You get to see the landscape of Kenya. And then on to the wards of a 400-bed public hospital called Moi University Hospital. Moi was a former president of Kenya, so he got to build a hospital in his hometown. I rounded with 6 Kenyan medical students and 1 Brown medical student on one of the services. And medical students in Kenya are taught in the traditional colonial British system. They're taught physiology, anatomy, and physical diagnosis. It's a great regimen. It's better in many ways than our medical education. The medical students are terrific. They're very bright, very hardworking. They're often from a poor background. And some of those students, I couldn't believe it, didn't have enough to eat. So they were working under those conditions. And they were great. The wards reminded me of my internship at the Brigham 30 years before. They were open 36-bed wards with 6 bays. The wards smelled despite the Kenyan nurses and janitors' attempts to keep them clean. The windows were open and a breeze blew through. There weren't enough beds, so the Kenyan patients were usually 2 per bed, head to toe, and sometimes 3 per bed. Big cast iron beds. We would go around and we'd talk to each patient. Habari, I would say, and they would invariably answer Nzuri. So how are you? And they would say, fine, no matter how sick they were. And many of them were really sick. Half of them would be in an ICU in this country. But there are no ICUs in Eldoret. And it wasn't unusual to have 1 or 2 patients die on the wards during rounds each day. The first day I started CPR on a patient who just coded, who just his heart had stopped. And they said, we don't do CPR. We don't have respirators, and CPR was pointless. The hospital charts were small pieces of paper on which minimal notes were kept. And we saw the whole range of internal medicine. We saw bleeding ulcers, pneumonia, diabetes, rheumatic heart disease. We also took care of acute psychoses on the wards. It was really intense. And half the patients in the wards had AIDS. 50% had AIDS on those hospital wards. It was incredible. So we would examine each patient with our hands and our eyes and our stethoscopes, and then we'd make empiric diagnoses. We started treatment with the medications available that day, and the drugs varied from day to day. I would say, do you have ampicillin today? And, determining, which drug we actually could use, and we hope for the best. We look at the chest x-ray, and we use the window to look at the chest x-ray. And even better, if we really had to, we'd go outside and use the sunlight directly. The x-rays often revealed tuberculosis, which is very common. Patients with AIDS are particularly susceptible to tuberculosis. And tuberculosis follows HIV like a shadow and kills them. So a very common disease. Unexpectedly, the whole experience was exhilarating because the medicine was so intense and my role as a physician was critical to the survival of my patients. And I was teaching as well. After the first day, I thought I could have had, if I could have a small office in that hospital and round on those wards each day for the rest of my life, I would have been satisfied. And I was serious. Some US doctors who travel to Kenya end up staying for years. But I knew that, Rena probably wouldn't approve of that and she was not going to let me do it. But it was a wonderful, wonderful experience medically, but very, very frustrating. So I had a 20-year-old young man the first time I went over. He went into a coma on the wards and needed a CT scan. There was only one CT scanner in Eldoret, and it was not in the hospital. Patients paid for all the tests, and if they couldn't pay, they didn't get the test. So the family couldn't pay for the CT scan, so we doctors offered to pay, and the CT scan showed tuberculosis and hydrocephalus from increased pressure in the brain, and both those things are treatable, the tuberculosis and the increased pressure. We needed to pass a shunt, a plastic catheter from the brain to his veins and relieve the pressure. So I called the surgeon, and I was getting pretty frustrated, and he said he'd be glad to do it, but we needed to get a shunt. I said, what do you mean? I said, is there a shunt store? I said sarcastically. He said, well, you got to pay 2,500 Kenyan shillings, or about $7 at the time. So we were in the process of buying a shunt on a Friday and planning the surgery on Monday. And he died on Sunday. So a totally preventable disease. It was just absolutely totally frustrating. And AIDS was a disaster in Kenya. There was no testing, no CD4 counts, no viral loads. And unlike the US, in Kenya, the entire population was affected by HIV because it spread heterosexually and from moms to babies. There were well over 100,000 people in our area with HIV and no drugs, no antiretrovirals. When I went over, I took a large suitcase filled with leftover drugs from our clinic. And we sat on the floor, I remember one night, divvying these drugs up to see how many patients we could treat and for how long. And by the way, what we did, I'm sure, was highly illegal. We could treat 50 patients for 1 year, and that's all. The Kenyans didn't like to talk about AIDS. On the floors, when I said that a patient had AIDS, they'd take me aside and say, Dr. Wing, we don't talk about AIDS here. It's too discouraging to the patient. And the trouble was, everybody was denying the problem. So the whole society was denying it. Many denied that it even existed. Some said it was due to witchcraft. And some men even thought they could be cured of HIV if they had sex with a virgin. Doesn't work. I tried to counter this denial by talking, by giving lectures, etc. One of the Kenyan medical students came down with AIDS when I was there. And he had CMV retinitis, that same eye infection that the priest had. And he was one of the first patients in the area who could be treated with antiretrovirals. We also got his treatment for his eyes, and his eyesight was not perfect, but it was the deterioration was arrested, and he was okay. He was thrown out of the medical school and out of the dorms because he had HIV. But we were able to get him back in eventually, and now he's become a spokesperson for HIV in Kenya. So we saw advanced HIV and all its complications. I remember a patient with Kaposi sarcoma covering his entire skin. So that tumor that occurs with people with HIV. We saw tuberculosis in all of its manifestations. We saw severe diarrhea, wasting, and dementia. So I had another patient who was really memorable. She was a very pleasant lady in her 40s, and she had AIDS and developed severe shortness of breath and chest pain. And she had tuberculous pericarditis, the lining around the heart. And in her case, she had fluid around the heart, and it compressed the heart. She was dying and needed immediate drainage. The surgeons had always refused to operate on people with HIV because their prognosis was so poor. Because HIV medications had just been made available at that time, we pleaded with the surgeons to operate on her. They went up to the wards. I was always surprised at this. They had a catheter. They stuck it right into her chest, right into the pericardial cavity. Fluid shot across the room, hit the wall, and she immediately got better. She could breathe. Just her chest pain stopped, and it was the pressure which was killing her. So, and then we got antiretrovirals for her, and she got better, and she became a spokesperson advocating testing for treatment for HIV patients. Unfortunately, several years later, she was found to have advanced cervical cancer, and she died. That's a preventable disease. We do pap smears in the US. And at that time in Kenya, it wasn't widespread, could have been prevented, and another tragedy. So as a physician on the ward, you're always a little concerned, am I going to get AIDS? And I was actually, it's a low risk, but I was taking care of a patient who had advanced AIDS, and I was annoying him. I was trying to look in his mouth with what I had as a tongue depressor, and he spit in my eye. So culturally, that's somebody saying, I am really angry at you. So he may have had a reason for that. The risk to me was low, but it wasn't zero. It was a body fluid coming to a mucosal surface. So I took antiretrovirals for 2 weeks. And I can tell you, it's really tough to take those drugs. You get very sick to your stomach. So all of a sudden, I appreciated what my patients were going through. Everything changed in 2003. And in that year, President George Bush's PEPFAR program brought effective antiretrovirals to Kenya. So all of a sudden, millions of people could be treated. And immediately, people wanted to be tested. They wanted to be treated. And as in the US, the mortality fell and patients were saved. I went back to Kenya each year for 1 to 2 weeks at a time and saw a dramatic improvement in HIV care, gradual improvement in the medical care, and an economy which grew, is growing at 5 or 6% a year. So Kenya has been doing much, much better. And in subsequent years, I spearheaded the establishment of similar programs in the Dominican Republic and Haiti. And I can tell you, the Dominican Republic has much better facilities and medicine than did Kenya, but they still had HIV and tuberculosis and tropical illnesses. Haiti, on the other hand, was a step below Kenya. The facilities were terrible. Malnutrition is rampant in Haiti, particularly in the children. Tropical illnesses like filariasis and dengue were very common. And as in Kenya, HIV and tuberculosis walked hand in hand. The government was much worse than Kenya. Kenya is not great, but Haiti is it's almost absent. But each of those programs remarkably has grown. They've involved more students and residents and faculty. And each year we have Kenyan and Dominican students and residents come to Providence to experience Western medicine and culture. And each of these programs has been some of my favorite legacies. So just a few comments about HIV and the modern antiretroviral therapy era in the US. So in 1997, the mortality due to HIV in the US had fallen by 45% due to those drug combinations I mentioned. And advances in the drugs have occurred ever since. In the same year, we had 2 pills combined into a single pill. It doesn't sound like a big deal. To an AIDS patient, it's a big deal. It cuts down on the number of pills. And soon after, 3 drugs were combined into a single pill, taken initially twice a day, but then eventually once a day, a huge improvement in terms of HIV treatment and in the eyes of the patients. And further work in the coming decades developed a new class of drugs called the integrase strand inhibitors, which are remarkable drugs. They work by an entirely different mechanism. They're very safe, not a lot of side effects, and highly effective. And then at the beginning, as I mentioned, just this last year, a new combination has been developed where you can get an injection once every 2 months, and that's it. You don't have to be taking pills every day. You don't even have to be tested very regularly. So it's an incredible advance. And I'm no rooter for the pharmaceutical industry, but the HIV medication story is an incredible tour de force, I think, in which the industry put billions of dollars into their research, developing these drugs, and they produced life-saving drugs for people in this country and around the world. Their profits were astronomical, but the system worked and produced these drugs. Over the last 20 years, I've had the privilege of taking care of hundreds of HIV-infected individuals and have been able to get a glimpse into their lives and their struggles and their challenges and their triumphs. And by and large, as I said at the beginning, they're a courageous group of people who faced up to their disease and the accompanying shame and stigma. The newer drugs have allowed them to live normal lives. I now treat hypertension and heart disease, kidney disease, and their arthritis. They're facing the problems of old age, like this group I'm talking to, and which I described in that article for the talk. And HIV patients are in general just like the uninfected population, all right, except for perhaps having a wider and, to me, much more interesting, indeed fascinating, almost Shakespearean range of characters. So in general, though, most of my patients were men who have sex with men. They were very matter-of-fact about their disease. They're careful with their medications, and they lead normal lives and are not particularly affected by HIV. But I want to describe one man who I've taken care of for years. He's a man originally from Southeast Asia, and he presented with AIDS and tuberculosis in his abdomen, and he was sick. His CD4 count was less than 10. He nearly died. We started drugs for tuberculosis and HIV. He initially improved, but several months later, he became desperately ill, and he had something called the reconstitution syndrome, where the immune system starts to recover and then overreacts to the pathogen, in this case, tuberculosis, and it almost killed him. He was in the ICU for several weeks. He eventually recovered, and I followed him for years, seeing him through a divorce. He talked about his children growing up, 2 kids who graduated from high school, 1 from college. He morphed into a chubby, middle-aged man, satisfied with his normal, healthy life. I've become a general internist for him, just follow him for his hypertension and his cardiovascular risk. His HIV is a chronic condition which was completely under control and almost an afterthought to me. So a huge success in the modern era for the medication. I also took care of 2 upper middle class patients who were a contrast in attitude. One was a woman in her 40s who was divorced. She had a really good job. She was absolutely devoted to her teenage daughter. She was very cheerful. She took her medicines. She had a high CD4 count, leading a normal, conventional life. I saw her every 6 months and could confirm that her control of HIV was excellent. I'd screen her for other conditions like her cardiovascular cancer risk, provide her advice about healthy living. Her HIV was under good control, and I always felt good after seeing her. In contrast, I cared for a middle-aged businessman who seemed horrified by HIV and the fact that he had the infection. He took his medications, but he couldn't stand to come into the clinic and be around other HIV people. I was lucky to have him come once a year, and when he came, he acted as if the clinic and I were his worst nightmare. When I went to check his blood work, he was in good control, indicating he was taking his medication. But I have no idea whether his family, his wife, or anyone knew his diagnosis. And I felt for him because his infection was such a burden for him. Whereas the woman I just described regarded it for what it was, a totally controllable chronic condition that shouldn't affect your life very much at all. And finally, I cared for a transgender patient in her 30s who was very compliant with her HIV medication. She had cosmetic surgery, which was successful, worked out very well for her. Her other medical problems included obesity and arthritis and opiate drug addiction. She had a long history of that, but it was controlled with Suboxone. So she was great. Some of my transgender patients had some of the most difficult lives. They were often poor and had to deal with extreme stigma and prejudice imposed by an intolerant society. Really, for them, it was the worst. And they often had difficult childhoods and were in abusive relationships. Substance abuse was common in that group. But despite these challenges, they usually showed up at clinic, took their medicine, tried to face the stigma and difficulty in their lives with what I thought was grit. I stopped seeing patients in 2021, a full 40 years after that first news report about young men in Los Angeles with pneumocystis pneumonia. I've been privileged to care for and have a special window into the lives of all the patients that I've cared for in the US, but also abroad. And it's been a wonderful and eventually victorious journey for my surviving patients. And it was one of the most meaningful and satisfying parts of my life. That's it.
Thank you, Ed. That's really, when you describe it all on a personal basis and what it's meant to you, what I heard was lots of frustration with society and how they dealt with this when you were right there personally dealing with these individuals. And what I hear in that frustration was also a sense of privilege that you were dealing with people's lives and their mortality. And I just wonder, on the long run, to be able to see all of this, it must be a wonderful feeling. But as new diseases come along, you see in the frustration, and how you, my question to you is really how over a period of time have you dealt with this? Has it just been because you've been dealing with the people, the individuals? Because there's got to be a huge amount of frustration that you've experienced in dealing with HIV.
So I think the worst thing was seeing the prejudice within the society. I mean, these people were stigmatized. People wouldn't touch them. And it's still true. If you hear somebody has HIV, you go, well, you know, there's a sudden withdrawal. It's just an infectious disease, for God's sake, you know. So it was stigmatized in part because of the groups where it was first identified in this country, but the continuing stigma to that disease and to other diseases is very frustrating. Yeah. So how do you deal with that? I mean, it's gotten better. I think education is the key. I think books are very important. I think that there's people describing what's going on with that, I think is very important. I don't have a magic answer.
I'd like to just
the frustration. Yeah.
To add that he is really a true hero, because there was a huge amount of fear about this unknown infection that no one knew where it came from, and it might be transmittable. And a lot of doctors, as well as all the rest of society, wouldn't get near a patient or treated patient with AIDS because of the fear of contracting it. And he went right in there, both here and abroad, and mixed with all these people, treated them, put his hands on them, and changed a lot of lives. That's quite admirable.
Yeah, you know, but I didn't do anything different than what we're supposed to do, and what was in our oath. And that's always been true with physicians. Physicians have always been on the front line. If you look at the Ebola virus epidemic, doctors are the ones who died in the hospitals, and nurses. So it's just part of our profession. And the people who didn't do it are reprehensible. I think it's terrible.
Mm-hmm.
They didn't follow what they should have done. Yeah. Thank you, though.
Thank you. I think what we want to do now is to break up into smaller groups, and certainly we have an awful lot to think about. But really, what's happened to us is we've had the AIDS epidemic, and we've had Ebola, we've had things separately. And people have been able to say, I'm not part of that group. But we've had COVID, which has come, and I think that's made a different, possibly some different feelings about infectious diseases. And I think that what would be fun for us to do is to discuss our perception of infectious diseases at the time of HIV and Ebola, when they were coming into effect, and how you see them now through the lens of COVID, and how do we see infectious diseases. So I think if we just break out into the groups, and I know Alan, you and Larry can do that, and we'll do that for 12 minutes and then come back and have some question and answers. And thank you, Ed. It was just a fantastic presentation, and I really feel that there are going to be some question and answers questions in the period after our breakout groups. So
there's going to be 6 breakout rooms. The last 2 have 4 people in it, and Alan and I will join those rooms. The others will have 5, and in each room there's one of the committee group or Ed to lead the discussion. So I'm going to put you in the rooms right now. First,
I didn't have a question. I was just following Larry's instructions.
Oh, Ron Bodenson, you're first. Go ahead.
So Ed, my best friend from high school was gay, it turned out, and he had a very good friend in New York in the early 80s who got AIDS. And they had money and they were looking for drugs. And they learned that France had cutting edge drugs. And they would go to France to try to save his friend John. And they were so frustrated in the mid 80s that the US seemed to be obstructing the development of drugs, or at least not letting drugs in from foreign countries that might help people. That was the impression. And of course, John came home from France and died. And then it seemed to break open in the late 80s. What was your experience with the US government helping or hurting the production of drugs, these cocktails that later were saviors?
Yeah. So 2 things. I think the government was terrible in their denial of the significance of the problem, and also probably some homophobia. I mean, Reagan was not willing to put his efforts behind the efforts in the epidemic. My impression of the science is that it's sort of, some of the early stuff came out of the NIH and then picked up by the drug companies, and they developed, and the science marched along okay. I think the gay community was very frustrated. They were dying, and they saw the government not taking it particularly seriously and wanting to have some solution. But I don't think there was a good solution until the studies occurred, which showed how effective these antiretrovirals actually became. So, when I went to meetings during those eras, ACT UP, would come into the meetings, disrupt it, be yelling, at the infectious diseases people. They'd march down the aisles, and in inappropriate frustration with sort of the lack of progress, and I think also just the lack of recognition on the part of the government agencies of how serious this was. So I didn't see withholding drugs or not being able to get access. I think the minute doctors had something which is effective, we used it.
Peter Krause, you have to unmute yourself, and you're next.
Okay. Am I unmuted now? Sorry.
Yes.
Okay, sorry about that.
Where are you, Peter? Where are you, Peter?
Where am I? I'm here.
Oh, there you are. Some little square.
I'm in one of the little squares, yeah. So that was a great talk. I really appreciate it. I just wanted to make a couple comments. I did pediatric infectious disease, so I saw the kids with this, and that was an especially tragic aspect of it. About 20 or 30% of women who were infected would give birth to infected children, and it was very hard to see these kids die. And then a seminal event occurred about 10 years after the onset of the first AIDS cases, and that was a study was done. The NIH spent billions of dollars, I think, on research efforts to try to prevent or treat and prevent the disease. Anyway, there was a clinical trial where they used a drug AZT, which you mentioned, of course, and the percentage of women who had HIV and would deliver an infected child dropped from like 20 to 30% down to 7%. And then with further medication dropped even further. And eventually these pediatric clinics that treated HIV kids closed, and all the kids graduated to the adult care. And but that's it's a very sad chapter, and I saw a lot of kids dying, and it was really particularly horrible.
Yeah.
But anyway, it's an amazing story, no question about it.
Yeah. So you had the same experience I did then, really.
Yeah, I think you went beyond the call, beyond what I did, Ed. I mean, you were seeing a lot more patients, I think, and the fact that you went overseas and did all that work is really, really commendable, really great. But yeah, I think one of the other thing is this idea of fear initially. There is really tremendous fear because, it was one thing 5 years, 10 years later, understand the transmission, understand you could take prophylactic antivirals. But at the beginning, you didn't know. And there were healthcare workers who stuck themselves with a needle after they drew blood from these patients and died. And
Right.
surgeons who died, and others, who died from this. So it was, but as you said, Ed, that's, this is part of the job and you do it. And fortunately, I didn't know too many physicians who decided they couldn't do this, but some did.
I thought a group that was heroic were the surgeons at Bellevue Hospital, which was inundated with the AIDS patients. And they just kept operating on those patients. They knew there was a risk, but they fulfilled their duty. And I regarded them as particularly heroic in this.
Rick Ackerley, you're unmuted, I think, and I'm sure you're going to lift our spirits with a hopeful and open question.
How did you know that? So, a theme in our conversation was how impressed we are about your discipline to the Socratic Oath and just doing your job and just chugging away. And it was heroic. The word heroic came up in my mind before you even said it. So that work is heroic. We are curious about the effect it had on you at the time, in those difficult times emotionally, perhaps, you and your wife or whatever. I mean, what are the personal challenges of hanging in there day after day after day?
So I never regarded it as heroic. It was just my job, right? And I think most doctors felt that way. I think it took a real emotional strain, though. You had patient, as I said, my field is a field where we do cure most people, and we couldn't do it in this circumstance. And it was just like going back in time in terms of being a physician. We couldn't alter the course of this disease initially, and so extremely, extremely frustrating and difficult. I think Rena, she had her own career. She was extremely supportive. I don't think she worried too much about that. But after I got spit in the eye by this guy, the chances
Yeah, how about
were really
that?
low. But other people had needle sticks and things like that. So, but it was interesting. I took medication. I didn't test myself for a couple of years, which is real denial, right? I didn't want to know. So I just ignored the whole thing. So that's pretty wrong. I should have tested myself right away for my wife. So I was pretty sure I was okay, but so a lot of emotions swirl around that. But doctors are pretty good at walling everything off. We inure ourselves to the emotions. Yeah.
Other questions? Raise your hand by the bottom. Bill Taylor, you want a question? Have to unmute yourself. There you go.
Hey, Ed, great talk. I enjoyed your article on HIV and aging, and one little paragraph caught my attention. Can you hear me?
Yep.
Yes.
Okay. One paragraph caught my attention. You mentioned that some of your HIV patients had reactivation of herpes viruses. In your case, it was cytomegalovirus. But I have a sister who had a condition that in her case, the reactivation was Epstein-Barr virus, the monovirus. And she ended up taking IVIG finally with dramatic improvement. I was just wondering, did you use IVIG on any of your patients who had reactivation of herpes viruses?
So the herpes viruses in general, you can treat. So herpes viruses 1 and 2, cytomegalovirus you can treat. Epstein-Barr, we don't have particularly good treatment for. So you're right. So IgG can be used for that. And we use that for other conditions as well, where we don't have effective antibiotics. So you're basically giving somebody antibodies
Right.
to treat or protect against an infection. Yeah.
Did any of your patients get the IVIG with good results, or do you know? Or
I don't recall doing that myself.
just
I'd have to go back and look. Yeah.
reason I brought it up, my sister aged 10 years in about 2 years with her condition. Once she got treated for the herpes virus,
Yeah.
it reversed. You know, she's improved dramatically in a year. It's amazing. I just was thinking there's just something to fall back on if you had any patients with herpes viruses, but nothing else worked. Hers, that was all that worked. The other treatments for the viruses didn't. But thanks again for your talk. It was great.
Yeah, so just Epstein-Barr virus is a virus that most of us are exposed to as kids. And it is, it causes mononucleosis, particularly in teenagers. But most of us have been exposed to it, and we sort of live with the virus for the rest of our lives. But it can reactivate. It can actually be associated with lymphomas and other conditions as well. So, yeah.
And I'm curious, as a professional in the field, are you surprised at the general population's turn against science, vaccines? What's your view?
Yeah, we talked a little about that in our group of vaccines, and vaccines are probably the most important thing. I think Peter might back me up on this. The most important advance the medical science made in terms of controlling infectious diseases. So we've protected against the childhood illnesses, which used to ravage our kids. 30% mortality, 40% mortality in young kids with things like diphtheria or measles, and so vaccines we know work. Most people are vaccinated against those diseases. But ironically, when they're adults, they say, oh, God, I don't want to be vaccinated. And so the coronavirus vaccines are a complicated situation. It was a new vaccine, new methodology. We're injecting RNA. So people got, and there wasn't the complete data behind it that we would have liked. So it was complicated. But it's ironic that people were against vaccinations, which have been proven over and over and over again to be safe and effective. Yeah, and particularly these RNA vaccines developed for COVID, and they'll be used for many other vaccines. So, yeah.
Alan or Huff, do you want to unmute?
I was going to say, Jim, you want to unmute? I think we'll take one more question. And I think from a time standpoint, unless we've got others hanging out there, we'll move ahead. Jim.
So Ed, I thought that was an incredible story, and I'm very impressed. And I wonder how much association you had with two pretty famous physicians, some of whom had training in your institution and were in your field, and what your reaction is to death threats against Fauci and your association with Paul Farmer.
So Tony Fauci and I go way back. He was very supportive of me during my career. So I've known him, and I think most infectious disease people seem to know Tony. I thought Tony got too far out there in terms of being such a public figure. And so he came across to some people as very dogmatic, even as the field is changing. So, but I think he was the voice of reason for during much of the pandemic, but I think he got a little ahead of himself. Paul Farmer is somebody who I've met and talked to. I don't know him, didn't know him well. His work in, he's the type of guy who would take one patient, and that patient was everything. He would drive, it didn't matter what, he would hike 20 miles through the jungle with a patient on his back, to take care of them. It was like that. There's a certain number of physicians who are like that, who are totally dedicated. And he was dedicated to his clinic. He was someone who was almost messianic and saw the light and did fabulous work. So those are all very positive things. Yeah. There's another side, but he's very positive. Yeah.
Thank you.
Well, thank you all, and thanks for the questions. Ed, thank you very much. That was an incredible presentation, and I think we all really appreciated hearing from you and staying in touch with you. And we really thank you for putting this all together.
Thank you very much.
I want to also tell everybody that your group of officers and committee are working very hard. It's John Vipon and Alan Stern, Larry Ricketts, Harry Tether, Ken Wilcox, Ron Bodenson, Gordy G, and me. And we've gotten really, for the next year, I think we've gotten some very interesting talks coming up. Our next one, however, which you should all program into, is going to be an interesting one with Scanlon Gale, formerly John Gale, but is now known as Scanlon, is going to talk about his life in the entertainment industry. He's been in the entertainment industry since actually before he came to Williams, and continued with that. He had really, I think, 2 generations of his family, and his brother went in the entertainment industry. And so we'll get an insight of what it's like to have been an actor and to continue to be one. So we're looking forward to that on January 19th, and you'll get some information on that, and then we'll go from there. But we have a whole slew of people lined up, and we're really excited about continuing this group. So thank you all for participating. It was nice to see everybody here, and it's really was great also to be parts of the small groups too, because I think those are always interesting to hear what others say. So good night to everybody, and thank you all, and particularly Ed, thank you so much.
Sure.
Brilliant career, Ed.
Thank you.
Thank you very
Great.
much.